Well, I'd like to take this time and thank all of you for staying through the day and attending our webinar. I found the speakers to be very knowledgeable and informative, and at this time I'd like to give you some thoughts and closing opinions regarding this event. The first is that COVID-19 has had a profound impact on healthcare and frontline workers. A report just published in the American Journal of Infection Control from Thailand surveyed hospitals during the COVID-19 pandemic and found 71% reported staffing shortages and only 46% of infection preventionists felt safe at work. The Los Angeles Times published a news story which described a significant outbreak at the Los Angeles International Airport where at least 400 confirmed cases among Transportation Security Administration staff and workers at the American and Southwest Airlines. Now, these cases were not defined as hospitalizations or ICU admissions, but they were cases where we had a number of workers that all at once got sick, and it impacted the ability of LAX to perform its functions. And this, I think, is very significant, that even mass infections of workers, even if it is a mild case, if a lot of workers are off at the same time, you'll have decreased competitiveness of our industries. And so we have to control disease. We have to pay attention to public health strategies. COVID-19 not only affects healthcare workers, but it has also affected patients. Hospital onset COVID-19 is a significant problem. In February of 2021, the Scientific Advisory Group for Emergencies out of the United Kingdom estimated at least 8.8% of COVID hospitalizations were hospital-acquired infections. Some of the trusts had extremely high infection rates, whereby 64 to 54% of patients who died had COVID-19. The Daily Mail reported that nearly 9,000 patients died after catching COVID in English hospitals. There was a total of 32,307 patients which caught the disease, of which 8,747 died. So this is a significant problem. COVID-19 can affect hospital workers. They can spread it to patients, and patients can also spread it to staff. So it needs to come under control. The National Health Service has implemented strategies to mitigate this problem. However, in the United States, I'm afraid no one is really counting hospital onset COVID-19. The metric for SARS-CoV-2 healthcare-acquired infections requires that only current inpatients who contract COVID-19 14 days or more after admission be counted as hospital onset. This metric will capture few patients. One needs to consider that Omicron has an incubation period of approximately 3 days, and the average length of time a patient stays in the hospital is 4.6 days. Not tracking patient acquisitions of COVID-19 place both patients at risk and masks the need for mitigation strategies. And as Dr. Ali has pointed out, we are in for a wave of long COVID disability that may be very impactful on the ability of the United States to perform services and to maintain an active workforce. He estimates that long COVID affects between 4 to 7% of COVID-19 patients. There have been other studies that have been reported where this figure is double or triple this amount. The recent study out of the Netherlands stated that it was 1 in 8 patients, and they did not even survey for cognitive problems. And that study out of the Netherlands was a controlled study. So they subtracted out non-COVID patient symptoms. 1 in 8 is a large number. And as also discussed, COVID is not a respiratory virus because it can affect every organ of the body. So it can be respiratory, but not necessarily. The Brookings Institute has reported that in the United States, between 2 to 4 million workers are no longer working because of long COVID, and this comprises approximately 2% of the workforce. And I think the conclusion that Dr. Ali made is absolutely correct. Healthcare systems must adapt to provide post-COVID care strategies. Now, what needs to be done for COVID-19, I think, is self-evident. We need to keep from contracting SARS-CoV-2. the virus which causes COVID-19. We need to keep immunity as high as possible. If one contracts SARS-CoV-2 and are at high risk, you need to seek treatment. Now, Dr. Lydia Maraska really emphasized the importance of air quality and airflow, and I think this is one of the biggest take-home messages we have. The retailers, industry, workforce really still has the mindset that we're not dealing with an aerosolized virus. Most of the precautions I see in Kentucky are mainly for precautions from surface spread or large droplets. It's not for aerosols. In medicine, we think of aerosols as being small solid particles and droplets being large particles, but we've learned today that aerosol science, airborne particles can be either liquid or solid, and there's a continuation of sizes. With smaller particles less than 5 microns, aerosolizing the most easiest, but even large particles can aerosolize, and the smaller particles have a higher viral concentration. And what is key is upgrading air quality and airflow. That's of critical importance. And of course, we discussed about the use of upper room UV lighting for disinfection. Ventilation requirements depend upon occupancy and room size. CO2 concentrations should be below 870 parts per million. A Harvard study found that there's large differences in cognition. So this is regardless of whether or not you catch SARS-CoV-2 or diseases. This is just your ability to stay awake and to concentrate, and that there's large differences in performance between CO2 levels of 550 parts per million to 1400. Now, to put this in perspective, I actually have one of these portable CO2 monitors and go around and measure CO2 levels. It is a rarity when I can find a place with closed windows, it's indoors, that has a CO2 concentration below 1,000 parts per million. And that includes where I live, it is oftentimes above 1,000. And needless to say, our goal should be having this below 800, possibly even around 500 or lower. And we're nowhere near this in some of our schools that have broken down HVAC systems and you can't open the windows. Now, prevention is also key with clean surfaces. This was elucidated by Dr. Steinman. And I think one of the key take-homes for me is that when you're at home, soap and water is a pretty good option. You don't have to be washing down your counters with disinfectants and with hand sanitizer. Soap and water with this virus, the protein lipid capsule, should be a good alternative. And also, we need to think about using N95 masks and to keep immunity as high as possible. Now, there was a very good study and report that was produced by the Rockefeller Foundation in March of 2022 entitled Getting to and Sustaining the Next Normal, a Roadmap for Living with COVID. And as you can see by this chart, an N95 fitted mask was found to be twice as effective as a non-fitted mask. But even a non-fitted mask was over twice as effective as a surgical mask, and a surgical mask was more effective than a cloth mask. But many of these masks can be defeated if you have enough exposure or if you're in the high-risk setting long enough. So in my opinion, the best alternative is if you're in a situation where you're going to be indoors and it can't be avoided, an N95 mask is by far the most preferable option. And these are readily available at this point on Amazon. And to keep immunity as high as possible. I'll be honest with you, at my age, and I think many of the public just gets confused when you talk about the different types of shots, the different type of boosters. All of this is variant dependent, whether it's pre-Omicron, pre-Delta, post-Omicron, BA5, BA4.6. I mean, it gets very confusing, and all of the results of your immunity and effectiveness of your immunity will be different depending upon the combinations. And so the take-home message is, look, all immunity is waning. We're getting hit by hybrids. By the time you get a study done, there's a new hybrid that's already invaded your community. So just keep your immunity as high as possible. You will at least have some cross-reactivity and immunity to the variant. And if your immunity is high, you may have, I think, have good protection against severe disease being hospitalizations and death. And that's not to mitigate that the so-called parentheses mild disease, if you get long COVID, can be lifelong debilitating. Now, one of the factors that I thought was peculiar was our overemphasis on case fatality rates as a public to determine when or not a variant is safe or I could go outside. And this isn't the whole story. You also need to look at infectivity, because what I'm concerned about or the public is, if I do an activity, what is the risk to myself of getting severely sick if I do that activity? And that's a combination of case fatality rate and infectivity. So for the Omicron surge, the United States produced more deaths than Delta. We produced far more illnesses and infection than Delta. But unfortunately, if you became infected with Omicron, your immunity was not long lasting, and it was much weaker than if it was elicited than Delta in previous strains. So by any measure, Omicron was the much more dangerous variant than Delta, but yet the public had the impression that, well, this is a mild disease, we need to relax up on strategies and what we are doing, when in fact it was the opposite. Now, treatment, Paxlovid is by far the most effective oral treatment. There is a new study out in the New England Journal of Medicine, this was out of Israel, which found that it produced excellent effects in those above age 65 in the prevention of hospitalizations, but below age 65, they did not document an effect. Now, this is just one study, but needless to say, just don't go around with the mindset, if I get sick, I'm going to take Paxlovid, I don't need to worry about it. We need to view this as a layer of armor, one of the things we add to other measures. Now, also monoclonal antibodies, these are extremely effective depending upon the antibody used and the variant. Evusheld has been one of the mainstays that we've been using, and it's still effective against the BA4 and BA5 variant. However, the BA4.6 variant appears to be escaping this treatment, and it's now on average in the United States about 10% of isolates, but in some regions it's much greater. So Evusheld is not a for sure thing, because unfortunately, when you have to give the monoclonal antibodies, you're not going to be giving the results back yet. And of course, Evusheld is primarily used for prophylaxis of people who are highly immunosuppressed or who've had organ transplants. And now that therapy is coming into question. So again, we must maintain other measures. There's also one other monoclonal antibody, which is bevtelovimab. I probably pronounced that wrong, I'm sorry. And this is still effective against the BA4, BA5 variant. I have not seen data regarding the BA4.6 variant. Continuing education credits are provided by two different entities. One is Southern Kentucky AHEC. They are providing continuing education credits for a variety of different specialties, including nursing. For physicians, the credits are AMA Category 1 credits, and 6 credits will be provided. Now, for AHEC, you can claim partial credits, but you can only claim commensurate with your viewership of the webinar. And you have to register for the credits with the same email address that you registered for the webinar. Now, the next accrediting organization is the Ancc, and this is for nursing CE units. A total of 6 units can be acquired. And there are 2 requirements. One is that you have to have an evaluation form filled out for the event, and you have to attend the full program. As before, you have to use the same email that you used for the webinar, and make sure that that email is the same when you do the course evaluation and claiming your CE. If there are any problems, send me an email at kavanaugh.ent@gmail.com.